بسم الله الرحمن الرحيم. السلام عليكم.
وعليكم السلام.
صوتي واضح لكم؟
واضح.
Good evening, everyone. We welcome everyone through our fourth educational webinar of the Iraqi Stroke Network. And today we are hosting a resident summit because the residents are the first one who meet the patient, the first one who might take the decision. So the importance for educate and discuss with residents is of paramount importance. Before we start, we introduce the apology from Dr. Mu'taz Fayrouz. He had some issues today. He couldn't attend today. And we would like to present our empathy and sympathy to Dr. Hussam Abdul Rasul for the unfortunate death of his mother. He is one of the active members of our network. And without further ado, I will tell you the agenda of today's webinar. We will start with a lecture presented by Dr. Mustafa Al-Kharsan, and then we will open discussion in the Q&A box that will be read with Dr. Zahraa, and then we will close remarks. We will finish the webinar hopefully at 9 p.m. So without further delay, I'd like to present Dr. Mustafa Al-Kharsan. He is a chief neurology resident at New Mexico University at the United States. Dr. Mustafa born and completed his medical education at Iraq and then migrated to United States. Dr. Mustafa, the word is yours.
السلام عليكم جميعا. شكرا دكتور مصطفى على هذا التقديم. قبل ما ابدي بس بالعربي احب اشكر كل اللي حاضرين من اساتذتي وزملائي من الريزيدنت، واحب اشكر القائمين على هذه النتورك. الشبكه اعتقد هي خطوه طال انتظارها، بس ان شاء الله خطوه كبيره بالاتجاه الصحيح، مو فقط حتى تطوير النيورولوجي بصوره عامه، بس معالجه الجلطات الدماغيه بصوره خاصه. So I'll start my you can hear me, right? Like my voice is everyone can hear me good?
Yeah.
Can you hear me, Dr. Mustafa? Okay. So today I will talk about the review of thrombolytics indication and some changes that has come in the field. And we will talk, I have no relevant disclosure. And the outline of this talk will be going around the background of the thrombolytics indication. And also we will discuss in detail some of the indication and contraindication of the thrombolytics. And then at the end, we will talk about what are the new things that comes in that field, which I found interesting. And there's some like recent data, one of them that was like last week actually published. So alteplase or TNK, as we all know, now when I say alteplase or TNK, I will use it interchangeably, but when we later on will come on to tenecteplase, I will specify either alteplase or tenecteplase. However, TPA was a standard of care and FDA approved in 1996 after the NINDS trial, RTPA trial, or the NINDS trial for patients who presented within 3 hours with acute ischemic stroke, and for selected patients who are presented later on for like between 3 hour and 4.5 hour of last known. Well, just want to mention, like go over a little bit, not in very details, all the studies, but NINDS trial is a landmark in the field of ischemic stroke. And it was published in December 1995. And what they did in general, I know here a lot of information. However, basically what it says, they took patients who are presented within 3 hours of last known well with ischemic stroke, and they randomized them either to placebo versus TPA and alteplase in this case. And here they look at two things. First thing, they look at the improvement in NIH within improvement in 4 points in NIH score, which is the score that we use for like scaling the severity of the stroke. If there's an improvement more than 4 points, or there's a complete resolution within the 24-hour. And the second thing they looked at is the favorable outcome or the modified Rankin scale. Modified Rankin scale is a disability and dependence scale that's been used in, you will see in actually in all the trials to gauge the effect of the treatment. So they found that for the primary outcome, there is improvement. 47 here, if you see, like 47% of the patient who received the TPA was more than that versus 39% who received the placebo. There's improvement on the 4-point NIH score or complete resolution. However, these results were not statistically significant. So, but again, we will continue to resume as a standard of care, because when they looked at the second outcome, which is the favorable outcome of or the modified Rankin scale, they found 39% who received the TPA versus had improved on with the number of modified Rankin scale versus 26 of the placebo. Just to mention here the numbers, modified Rankin scale, it's a scale between 0 and 6. 0 where patient have complete resolution of the symptoms, 6 patient is dead. So the patient who had 0 or 1, 1 is very minimal disability or minimal symptoms, that there's no disability, minimal symptoms, and they can continue their daily activity without assistance. So it's a favorable outcome. They found their the mortality was also less at the 3 months in the treatment group who received the TPA, and higher on the placebo. There was increase in the SIH, ICH was the symptomatic ICH. There were increase in the risk of bleeding, 6.4% who received the TPA at the 36 hours versus 0.6% who received the placebo. However, despite that increase in the ICH, symptomatic ICH, the TPA were the standard of care for patient who presented with acute ischemic stroke within 3 hours of onset, and improved outcome at the 3 months. Then there's a lot of trials that happened to test what the effect of beyond the 3 hours. There's a lot of trials. I wouldn't mention all of them, but I want to, like a big one that happened in Europe, which is the ECAS-3 trial. That trial showed that, the goal of that trial is tested giving the TPA, which alteplase in this case, giving beyond the 3 hours, between the 3 and 4.5 hours. And also they assigned them to placebo and alteplase, and they look at the favorable outcome or the disability at 90 days, and it showed 52%, 52.4% on people who received the TPA versus 45% who received the placebo. So there's like improvement outcome in that case, in that particular window. And the symptomatic ICH were higher on that group, 2.4% versus 0.2, which is less than the NINSA trial. However, because it's European study, it's not an FDA approved, but the guideline and AHA and ASA committee here in the United States, the standard of care now, they included those patients. However, here the patient where, so right now the standard of care for any patient who present within 0 to up to 4.5 hour and FDA approved for only 3 hours, and selected patients beyond that up to 4.5 hours. And I just want to go over the AHA-ASA guideline, but I want first to talk about how we grade the class of recommendations. So, which is important as a neurologist, because nowadays, especially when we go to the end, you will find out there's a different committee, have different guidelines. And as a clinician, also as trainee, it's important to see what's the studies behind it, what's the strength of guideline, and so you can gauge your clinical judgment. The guidelines, that's how it's done in AHA-ASA. The class 1 is the standard of care. There's a good evidence, it's recommended, and we should do it. That's class 1 evidence. Versus, I want to talk about the class 3. Class 3 also divided A and B, where there's either no benefits of doing it or there's a harm. So it's important to know which indications or which treatments that are class 3, because the principle of medicine is do not do harm. So we should avoid those patients, those treatments or options. Class 2, it's in the middle, where either that's reasonable to do that, treatment, or there's no sufficient data, might be reasonable or might be considered. So it's something in the middle, and there's no significant, efficient data or sufficient data to support doing it. But at least it's not harmful, or there might be benefits. And that's the class of recommendation. Level of evidence is based on if they have randomized controlled trial, more than one, inside the United States or outside. That's kind of how strong is the level of evidence based on that class of recommendation. So here, I want to go a little bit in details about the indications of the thrombolytic or TPA and acute ischemic stroke. Obviously, as we all know, for 3 hours, it's equally recommended regarding the age. Above 80 years of old or below the 80 years of old, there's a class 1, actually with level of evidence A, class 1A, recommending, regardless of the age, you give the TPA above or below 80 years of age, which is sometimes when I started training, kind of combined, do we give to all patients? But there's a class 1 evidence that for patients also who have severe stroke, there is an increased risk of hemorrhagic transformation. But even when I say severe stroke, hereby I mean very high NIH score. And there's a class 1A evidence that even with a severe stroke, you give TPA. However, I want to keep your mind here, because when we'll talk about the class 3 or the contraindication, we'll talk about the CT scan. So here it's only about if a patient came in within the window with a very high NIH score, it shouldn't be exclude him from the TPA. You should give it, and it's class 1A evidence. And also there is, I'll talk more in details about the mild stroke. And it's I'm just going to briefly say here, there's a class 1 evidence for patients who have a disabling symptoms presented within the window, they will receive the TPA. And also for patients who with the extended period, 3 to 4.5 hours, also disabling symptoms, even if it's a mild, you will still give TPA. For the extended period, extended time, as I mentioned earlier, because of the ECAS-3 trial, for patients who presented after the 3 hours, between 3 and 4.5 hours, it's class 1 evidence if they have less than 80 or they have no stroke and diabetes, and also NIH less than 25. And they are not on dual antiplatelet or any anticoagulant, and also not dual antiplatelet. I would say no anticoagulant, and also without image with large stroke involving more than MCA. So that's the class 1 evidence, you include them, even though it's not FDA approved. Further, look at the indications here for people who are, when they get the TPA, their blood pressure should be less than 185 over 1A, also class 1 evidence, and also blood glucose should be above 50. And here actually, practically, that's most of the thing we do here regarding the labs to decide. We make sure they don't have hypoglycemia, and also their blood pressure is within the normal limits, and then we will go over clinically and decide to give the TPA. Now, there's a question if the patient had dual antiplatelet, like aspirin, clopidogrel, other antiplatelet, like Plavix, the clopidogrel. There is class 1A evidence that they will be eligible to get the TPA, so it's not contraindication. Other indication where is the end-stage renal disease. I know like a lot of people will afraid to do the CT angiogram based on like the kidney status, and if that goes a problem. Actually, even I didn't be, when I started training, I wasn't aware of this indication, because every patient who get the CT angiogram, it's not we don't care, but we give the CT angiogram for everyone, regardless what his kidney status. And then, but it's now to know it's class 1C evidence that those patients who had on hemodialysis with normal PTT, they actually eligible for TPA. That's indicated. If they have increased elevated APTT, you might have a discussion regarding there's an increased risk of hemorrhagic transformation. And here it comes to the question, do we wait for the APTT for those patients before giving the TPA? The answer is no. Like we give, if the patient is eligible and he have end-stage renal disease, we will give the TPA and wait, because at the same time the labs is sent in the ED, and if the labs came back with elevated PTT, you might have the discussion of maybe stop the discussion that's an increased risk of bleeding, and then have that discussion with the patients. But it shouldn't be excluded because studies showed they get benefits. And so now that's mainly the major like class 1 evidence for indication for the TPA. Here, before I go to the class 2 evidence, I want to talk about the class 3, which is cause harm or there's no benefits. It's important to know these like contraindication because obviously we don't want to do harm to the patients. Here, first one, as we all know, there's should be no prior stroke within the last 3 months, and also there's no head trauma, and there's no clear explanation about how they define the head trauma. But practically what we do is there's no skull fracture from that trauma, and also there's no, if it's acute, there's no loss of consciousness, and there's no, like when you examine the patient, there's no obvious trauma on the head. So acute and chronic actually. So acute, we have patients, like practically we have patients where it came in and they lose the consciousness and then they hit their head and they come with a big bump. We don't know if that's like lose of consciousness because of the trauma or not. We will exclude them from getting the TPA if it's obviously like a big trauma. Other contraindication is the GI bleed within the last 3 weeks, and we will talk again about the GI bleed later on in class 2. Wait for that. But also there's no structural GI malignancy, which is actually, again, when I started training, I wasn't aware of it, but it's obviously like it's a contraindication to get a TPA for patients who have a GI malignancy, structural GI malignancy. Obviously, no intracranial or spinal surgery, like a big surgery in the spine or in the skull, in the brain, for in the past 3 months. and no ICH, which is obviously a contraindication. But also, for patients who have a subarachnoid hemorrhage, if the symptoms are suggestive of subarachnoid hemorrhage, like headache, sudden thunderclap headache, not obvious neurological deficits, their CT scan at the beginning might be negative. So if the sign and symptom concerning for subarachnoid hemorrhage and not very convincing for acute stroke, there's a contraindication to give TPA on those patients. And also for patients who had infective endocarditis, because those patients have an increased risk of bleeding if there's infective endocarditis. Again, like they have a fever, murmur, or known to have infective endocarditis if they are inpatient and they call for stroke alert. And those patients, because they have mycotic aneurysm in the end arterioles, if they have infective endocarditis, and there's a higher risk of bleeding. And also, if there is a suspicion or confirmed with a CT angiogram, if there's aortic arch dissection, this is absolute contraindication to give a TPA. I just want to keep you in mind, what if they have not aortic dissection, but if like like ICA or intracranial arterial dissection, this is not a contraindication. The other contraindication is intracranial intraaxial neoplasm. This is also class 3 no indication to give TPA, and actually might cause harm. But for extraaxial, intracranial, but extraaxial, like meningioma, which is a very frequent finding in patients, like in practice, those are not a contraindication. It's just like intracranial, intraaxial neoplasm. We still continue on the class 3 patient who are taking anticoagulation. The guideline is mentioning no dual like DOAC, direct oral anticoagulation for the past 48 hours, or pertinent lab tests are normal. So here's the thing I want to mention. When we get a patient who will present with acute ischemic stroke as a stroke alert, we don't do like the labs we did is, as I mentioned, we send for it's like a point of care. At the bedside, we measure the blood glucose, but we don't wait for the plate count or the INR. We send for them, we start the TPA. If they are indicated, there's no contraindication. And then if the platelet came back less than 100,000 or an elevated INR or APTT, at that point, we will stop it. Unless like we know, like for patients with cirrhosis, we know his platelet is less than 100,000. At that point, we check before giving the TPA. Otherwise, we don't wait. Actually, even the recommendation and the guideline, we do not wait for labs in the ER before giving TPA. The other thing is for patients who getting the DOAC. Those patients, is I know, like the INR and PTT is not a direct measurement for the effectiveness or the effect of the medication. That's why it's not used in the ER. If we want to really know the effect, we should measure the factor 10A or the fibrin level, which is not found in the ED. So that's why practically, when patient present with dual like getting, I keep saying dual antiplatelet, sorry. For patient who got DOAC within the last 24 hours, we exclude them from getting the TPA because the labs will take long and probably gonna be out of the window. And the INR PTT is not a good indication. Sorry, not a good indicator of the effect. And if the patient is getting warfarin, then INR relatively come back fast. And if it's less than 1.7, we can give it. But again, in practice, if he's on warfarin, usually we don't give it. And Also, it's mentioned in the guideline, do not give aspirin within 90 minutes after starting or giving the TPA. And here, like, there's interesting thing I found is because before, like in practice, that we do in our center, when we give a TPA, we don't give sub-Q heparin like the DVT prophylaxis or aspirin until 24 hours. And those like rationale comes from the NINDS trial or the NINDS trial that they waited for 24 hours. However, in the recent in 2019 guideline, AHA guideline is only mentioned 90 minutes. This has come particularly important for people who went for, especially like recently, last month or last 2 months, we had a patient who came in with severe like LVO. He went for thrombectomy after getting the TPA, and he re-occluded within like 1 hour. So they took him again to mechanical thrombectomy. And at that time, they loaded him with aspirin. So the reason is now, in the guideline, it's not contraindication. You can give the aspirin if needed to rule out after 90 minutes of giving the TPA. So which is kind of a new recommendation in the 2019 AHA guideline. I don't want to confuse you here, but it's interesting to find that there is on the package of the TPA, there is like the company mentioning contraindication, which is not necessarily found on the AHA guideline. For instance, like obviously there's some common thing like current ICH, symptomatic like a subarachnoid hemorrhage, active internal bleeding, and again in the guideline is depend like on the duration, and also other, for instance here, like blood pressure more than 175 or diastolic more than 110. That's a contraindication or precaution. But we go with the guideline is if the patient have a systolic blood pressure less than 185 and diastolic 110, we give it so we don't go with these precautions on the package. Now, the other, we still within the contraindication, and the mild stroke. Mild stroke is kind of interesting, and we will talk more in details, but I just want to mention here, non-disabling stroke. Non-disabling stroke, regardless if they presented within less than 3 hours or the extended time, less than 4.5 hours, there's class 3 evidence, no benefit of giving that medication. So we don't give TPA for mild non-disabling stroke. However, we will talk about this a little bit soon, but let's finish with the CT head. The other contraindication for CT head for people who have hypoattenuation and severe extent of the stroke. And again, here they don't like identify specifically how they grade the hypoattenuation or however, for those patients will have like it's contraindicated to give the TPA. And because of have a poor prognosis despite giving the TPA, and also higher risk of bleeding. I know there's people use sometimes the aspect score to gauge, like for instance in UK also, they like if an aspect score less than like 3, they avoid using the TPA. But here I would like to ask you, for instance, this patient is one of my like colleague. Actually, he saw this patient, 93-year-old, and I wouldn't talk about the modified Rankin score before him, but he came in with this CT head, and I would like to see from the audience, because you see like on the left MCA, I don't know if you see my cursor, but like you see here on the left MCA, there's a very large hypodensity, indicating that a very large stroke. And this patient presented within the window. And I would like to see from, like, maybe in the chat, what do you think? Would you give TPA for this patient or no? I just want to, okay. In the chart. So NIH for him was above 20 to 25. I see yes, no. Couple answers, maybe wait, no. Okay, so there's a mix between no aspect low. Good, yeah. For aspect for him, good also indication. The aspect for this patient was calculated at 2. You know, aspect 10 is like the good CT head, and 0 is very like bad CT head. So yes, this patient ended up not getting the TPA decided by the team, and that's what comes with the AHA ASA guideline. Even if you don't count the aspect score for him, very large stroke, even within the window, you don't give a TPA. So here, I would like to talk about the further discussion, the class 2 evidence. And mild stroke is kind of like interesting topic, because in NINSA trial and even in other trials, it wasn't clearly how we, like the mild stroke and non-disabling versus disabling as well. Like, how we define disabling and how we non-disabling stroke. However, the guideline, what it says right now, if it's disabling stroke presented within the window, the 3 hours, there's a class 1 evidence, you give TPA. If it's mild stroke, and we'll talk about that a little bit, and non-disabling and presented and also disabling and presented within the extended window, 3 to 4.5 hours, there's a class 2 evidence they are eligible to give the TPA. However, non-disabling stroke, there's class 3 no benefit of giving the TPA within the window or the extended window. Now, I just want to give like a background on that topic, which is kind of a little bit interesting. So there's like the NINSA trial and also the international stroke trial, the IST3 trial with mild stroke didn't show significantly improvement. So were inconsistency the benefit of IV alteplase in those patients. There's also 9 trials, more than 6,000 patients showed improvement with mild stroke. However, the definition of mild stroke, like the NIH score from 0 to 4, were not consistent. And also there's an AHA go with the guideline registry. What found is those like 34,000 patients who have good functional outcome, and also for those patients who had like a mild stroke, if you treated them less than 3 hours or in the extended window less than 4.5 hours, there's no difference between in that regard, like in the modified Rankin score. However, those mild stroke at the discharge, 30 of them couldn't ambulate independently, or 29% couldn't go directly to work, and 73% had length of stay beyond 3 days or longer in the hospital, which make us think if they are like a mild stroke based on the physician, but they might do they benefit from giving the TPA or not? So to answer that question, actually, there is a trial came up, which is the PRISMS trial, and that what they did, they evaluate the potential of TPA for ischemic stroke with a mild symptom, and so they give either alteplase versus like aspirin and measure the outcome on that minor with acute ischemic stroke and minor non-disabling neurological deficits. So they give to the non-disabling neurological deficits. And what they found is there's no benefit of treatment within the 3 hours of onsets. However, this trial, even they just will go fast on. It was designed to recruit 900 patients. However, they ended up only getting 1/3 of those patients recruited, and the trial was stopped. And it was published in 2017, and as I mentioned, the primary outcome to see the favorable modified functional score, modified Rankin score at 90 days. And what ended up, it's only recruiting 313 patients, and the median time for the treatment is 2.7 hours, and the median NIH score was 2, and at the 90 days there was no difference between who received the alteplase versus like the aspirin. So based on this trial, the ASA guideline said class 3 evidence. There's no benefit of giving TPA for non-disabling symptoms. So now, again, the non-disabling or the mild stroke, do we go by NIH or like this? There's a very like kind of a gray zone. So I want to run these cases with you and see what do you think. There's a 53-year-old pre-modified Rankin score of 0, so no symptoms, experienced aphasia, and that's it. And NIH for her were 2, and no focal weakness, no numbness, and presented within the window. Would you give TPA? So I see here, yes, I would give, yes, disabling, correct. Yeah, fantastic, that's great. So those patients, because it's disabling for her, even though low NIH, those patients will go to get the TPA presented within the window. So this patient received a TPA. For her, no MRI was done because of the heart, like a monitor was not compatible, and modified Rankin score was 1 on discharge. Case 2, there's a 35-year-old female, pre-modified Rankin score of 0, right limb and facial weakness and numbness, and NIH was 4. After her CT scan, and her NIH was 1 for the numbness only. So just based on that information, would you give a TPA based on like her NIH was 1? So I see yes. So after, well, okay. After the CT had her NIH is improving symptoms, as you mentioned, and only for the numbness. However, on the exam, there were like a weakness, 4+ on the right elbow extension and also on the hip. So this patient, for me and my team, we considered that this is a disabling. So we offer the TPA because we think it's a disabling. However, this patient refused because her symptoms was improving and didn't get received the TPA even though it's offered, and her MRI for sure confirmed she had a stroke, and NIH was 0 and at the discharge. And this also, the last case, I just want to mention and specify like a concept behind that. 70-year-old, multiple vascular risk factor, pre-modified Rankin scale 1 to 2, with dizziness, unsteady gait, and NIH of 0. So he doesn't have any scoring on NIH, but he had a gait ataxia on exam. Would you give TPA for those patients? So I just want to see from the audience, what do you think? Great, correct, great. Yes. So that's what I want to emphasize here. Regardless of the NIH, posterior circulation stroke, NIH is not designed very good sensitivity for posterior stroke. It's for anterior ischemic, arterial circulation stroke. So, and also ataxia, it's disabling, and unsteady gait is disabling. So we will give TPA. So just like for the maybe my co-resident or the trainee, the PRISMS trial defined the disability is if the unchanged, or if the symptoms is unchanged, would prevent the patient from performing basic activity like bathing, ambulating, toileting, like ADL activity, or return directly to work. That's how you gauge the disabling. And also, so if that's something prevent him from doing his activity, that's considered disabling, regardless of his NIH. And usually what we consider, and again, it's not all the time, because sometimes sensory symptoms considered disabling, but usually the symptoms that is considered not disabling, sensory symptoms, isolated ataxia, dysarthria only, isolated facial weakness. But again, if it's like artist, that will prevent him from going to work, considered disabling. But usually if it's very mild old age, facial weakness, it's not considered disabling. And again, there's no clear consensus in the trials or on the definition. And also I want to pay attention to this subgroups. There is a patient who had a mild symptom, but at the same time, they have large vessel occlusion, LVO. So don't get deceived by only the CT head or only by the NIH, because there's a subgroup who have LVO with a mild symptoms. So CT angiogram is indicated here. In the realm of the dual, in the realm of the mild stroke, we talked about how we defined it or treated. I know it's not about the indication of TPA, but I think it's very important to mention these two milestone trials for mild stroke. So there's two trials right now. That's the guideline, class 1A evidence for patients with recent mild stroke, an IH less than or equal to 3, and there's non-cardioembolic, also obviously non-cardioembolic stroke, or TIA with high risk of recurrence, and we divide those people with this ABCD2 score. If they have ABCD2 score above 4, which is a score we like based on the age, blood pressure, central symptoms, and the duration of the symptoms. You can find it online and score those patients. For those who have a higher score, which means like a higher risk of recurrence, right now we do dual antiplatelet, which means aspirin plus Plavix, and we started it as early as possible, within 12-hour to 24-hour. The guideline mentioned here, even like you can start it within 7 days, but usually as soon as possible, and continue it for 21 days. And these indication that 90 days we do it for people who have intracranial atherosclerosis, but that's not my discussion here. For the mild stroke, we do it for 21 days, and that's class 1A, based on two trials, the POINT and CHANCE trials. So POINT trial, just very quick going off on this trial. It's American and North American, and also in Europe trial. They took patients who have a mild stroke, less than 3 or equal to 3 or TIA, and randomized them to either getting 3 months of dual antiplatelet, Plavix and aspirin, with load of the Plavix, 600 loading dose, versus only the aspirin. And they continued it for 90 days. And then after 3 months, 90 days, they measured different things, but the composite outcome showed lower incidence of stroke on the dual antiplatelet arm versus the aspirin alone arm. And obviously, there's a little bit risk of increased hemorrhage on those patients. And the CHANCE trial, it's in the Chinese trial where you do similar thing, however, mild stroke, or TIA with high risk of recurrence, defined as ABCD above 4, and they randomized people for 3 weeks of aspirin and clopidogrel versus aspirin only, and also they showed like a benefit. And here I just want like a very nice chart showing here, and that's why I want to mention why the 21 days came back. They combined it, they did a meta-analysis for those CHANCE and POINT trial, and they found here, if you can see, like in the y-axis is the difference in the events, and in the y-axis, the x-axis, you see the time, like since randomization. And if you are in the upper part, that's favored the dual antiplatelet, and the lower part, the aspirin. And it showed that the greatest benefits if it started as early as possible, but once you got to past the 3 weeks, like in the 4th week, both arms, aspirin and the dual antiplatelet, kind of combined, and there's no benefit after that. And that's why for the mild stroke who have less than 3, that's how defined, like NIH of 3 and less, we do dual antiplatelet for 21 days. I'm sorry, but that's back on the indication of thrombolytics, age above 80, and also pre-existing disabilities. As I mentioned here, it's a class 2 evidence for people who are presented more than 80-year-old within the window, even up to 4.5 hours. Multiple shown to be safe and effective. However, there's always a higher mortality and higher rate of symptomatic ICH if you compare to lower than 80 years old, but there's a good evidence showed its benefit on all age groups. And also, pre-disability doesn't seem to increase the risk of symptomatic ICH, but again, it's associated with less neurological improvement and higher mortality. The bottom line here, we consider alteplase on those patients. Seizure, it's a new recommendation in AHA and ASA. It used to be a contraindication, relatively contraindication, but now on 2019, seizure is not actually, it might be beneficial, and it's a class 2 evidence, because in practice, one of the mimics for the stroke is either seizure or like migraine with hemiparalysis. And usually what I do here, if the symptoms are suggestive of, if they come with a seizure and the symptoms are suggestive of focal deficits, if you have focal weakness, you look for other things that, like for instance, if he have right side weakness and his eyes deviated to the left side, then that make me think of it's a central cause and it's a stroke, rather than it's a thought paralysis, because some people with seizures come with thought paralysis, which is like a weakness on one side, but we can't wait until see the improvement. And also the other thing, for those people who have seizures, studies showed the risk of bleeding for those group, it's actually less than what it used to know, like 6%. Right now we say 6% there's a risk of bleeding when we consent, if we have a time, consent for the TPA, there's a 6% of bleeding. For those patients, actually, if they don't have a stroke, it's less than 6%, maybe less than 1%. So if I have a patient come with a seizure and clinically it's suspected to be from a stroke, I give them TPA, and I'll be assured the risk of bleeding is less. I don't want to pay more attention. It's a new thing regarding the cortical microbleeds. What we want to say here, for patients who have cortical microbleeds, there's no need for MRI to do before giving the TPA. However, if patients, and that's class 2 evidence, you can give them a TPA. It's not a contraindication. However, if the patients have cortical microbleeds more than 10, and there, for instance, if we happen to know that patient, my patient, and he had MRI, and there's more than 10 microbleeds, there's an increased risk of bleeding in those patients, but it's still it's a class 2 to give the TPA. And again, this is I don't think it's something very common to be seen in practice. However, if the patient is known to have a myeloid angiopathy, for sure we don't give TPA. Here, as again mentioned, regarding the GI and GU bleeds, it's class 2 for patients who have a GI bleed, and obviously after the 21 days. If before 21 days, we don't give a TPA. And here, the GU bleeds, it's removed from the contraindication. So even if they have genitourinary bleed, we give them TPA. The only contraindication is if they have a GI bleed within the last 3 weeks. Pregnancy, another kind of interesting topic. I haven't treated actually pregnant women with a TPA yet, but it's a class 2B, and there is not sufficient evidence to make it a class 1, so might be beneficial. However, with the Canadian stroke best practice guidelines, there's a recommendation actually. They recommend, that's not in the US, but for the fear of giving IV alteplase for those patients is to do intrauterine bleed. And the alteplase doesn't cross the placenta and doesn't expected to increase the risk of intracranial or systemic bleeding in the fetus. It's about the concern is about the intrauterine bleed. However, here the thrombolytic is should be considered, but after talking to neurovascular, because if the patient going for she has an alveole and going for thrombectomy, it might be we can hold on the alteplase. And this is an interesting topic. We can talk more about the end of the lecture about it, because right now, I don't want to proceed the slide, there is benefit of tenecteplase before thrombectomy. But again, these evidence happened recently, and by the time these guidelines came out, there were no such evidence. But so bottom line here, current practice, pregnant patients who are going for thrombectomy, we don't give a TPA. And this is also kind of common. Sometimes we have patients who had MI, either chronic or acute. The indication is there's class 2 evidence is to give them TPA. We don't exclude them, and they can go after that for the cath lab for with the cardiologist. Other indication, real quick, is for complication of the cardiac or cerebral angiographic procedures. Depend on if they don't have a contraindication, there's a class 2A evidence that you give them. For instance, if you have a 6-year-old female, pre-modified of 0, modified Rankin scale, and she went for cerebral angiogram for AVM, and then the stroke tolerant hair for NIH of 3, for expressive aphasia, mild right facial droop, and leg drift. Would you give TPA for those patients? I don't know what is the practice like in Iraq if you encounter a lot of those patients, but what do you think? Anyway, for those, when we got these stroke alerts, we considered the TPA for them, and we gave them. Other indication is which is usually like kind of a new recommendation because it was relatively contraindication before for patients who had lumbar puncture or who have a major like a big arterial puncture, like non-compressing arterial puncture. Now it's a class 2, they can go to TPA even after even if if it's presented within the less than 7 days. Okay, so here I talked more like about the indications of TPA and also the alteplase, and I just want to mention what is new that is coming in that era. And here, just 1 second. I don't know how I'm doing on the time, but I'll be fast. So, are there alternatives to alteplase? Here, where we come is the tenecteplase. Tenecteplase is now become new in the field where it's genetically modified variant of alteplase. It has a greater fibrin specificity, and it's longer half-life. So instead of an alteplase, we give a bolus of 0.9 per kilogram up to 90, and we give 10% at the first minute, and then the remaining over 1 hour. Tenecteplase, you give it only one dose, and you give it 1 time. And the dose right now we are using is the 0.25 milligram per kilogram up to 25 milligram. There's a lot of studies looked at the tenecteplase. I'm not gonna go over all of it, but the recent one is the ACT and TRACE. And after trial, what they did randomized people to tenecteplase versus alteplase, and what they found is when they looked at the 90 days of modified Rankin score or the disability score, there's no difference, as you can see in this picture. There's no difference between alteplase and tenecteplase. And what we can say here, tenecteplase is a safe alternative, or it's at least is not inferior to alteplase in those patients. And based on these trials, especially the ACT-1, the 2023 National Clinical Guideline for the Stroke in the UK and Ireland, they mentioned for people who presented 4.5 hours of last non-well, it's equal to easy use alteplase or tenecteplase, so it's equally effective. Now, however, this is important because that's how it started at least in my center. For people, that's those subgroup, for people who have LVO and they are presented within the window, tenecteplase showed better effect than alteplase before going to thrombectomy. So, it's those specific people, and that's the extend IA-TNK trial. This trial showed that for people who have LVO and they get tenecteplase versus alteplase, the outcome on those get tenecteplase is better than the alteplase. And that's how it started in my center when, like, I think it was last year, what we did any patient we know is going to thrombectomy, we give tenecteplase. Otherwise, we'll give alteplase. And then last year, we maybe more than a year, we decide to do tenecteplase for all patients. We are not using alteplase anymore based on these data. Now, there's another, I consider, I think it is actually a landmark study in the field of the stroke, because there's so many studies have been done trying to find if we extend the time beyond the 4.5 hours. All of them actually failed to show that timeline. However, the extend trial, and there's other trials as well, they didn't depend on the time for including the patients. They said, let's look at the tissue. So it's shift the paradigm from time-based treatment to tissue-based treatment. So what they did, they said, okay, we'll get a patient who have stroke and presented within, it was multi-center randomized trial, and they have an unknown last known well, and we will do CTP, if CT perfusion or MRI perfusion. And for those patients, if there is a salvageable size that is doesn't have a stroke yet, and we will see if we give them TPA versus placebo, and see how that improvements. And when they defined the mismatch ratio, I'll show you here. So they will define it. They get the CTP, and I know we discussed in the last lecture the principle of the perfusion, but in very brief, here there's a software. We'll get all the data, and while I am standing beside
Excuse me, Dr. Mustafa, for interruption. We missed the time landmark. Please hurry up, please, my friend. Yeah, no worries. So here it showed that for those people who had a large penumbra and low stroke, so the purple is a stroke, penumbra is ischemic, is a large one, it's improved, benefited from the TPA. And this trial was stopped because came up of the Wake Up trial. The Wake Up trial, what they did, it's still depend on very brief, still depend on the tissue. They did MRI, and they look at the MRI on the DWI and the flare. If there's a mismatch on the flare and the DWI, they give it TPA, and if there's no mismatch, they did not give it TPA. And those patients, as there's a mismatch, there's improvement of the modified Rankin scale. So what I'm trying to say here, and there's here a meta-analysis, here the guideline in 2023, the patients who presented after 4.5 hours, up to 9 hours, and they have on the CT perfusion or MRI, they have a mismatch or a potential salvageable brain tissue, they will give TPA for them. This is the last trial. I just want to mention it's come up in 1 minute. Came up in last week, which is timeless trial. It's a new trial which is happening in US and Canada. They used TNK for stroke for people who have a 4.5 hours to 24 hours, and they randomized them to get TPA, and they randomized them to receive tenecteplase or placebo. And this trial actually kind of didn't show improvement. So for the people beyond 4.5 hours who get tenecteplase, there's no benefits or improvement on modified Rankin scale. So it's kind of negative trial. However, it showed it is safe for those people. But again, I just forget to mention, the timeless trial, you need to have a salvageable brain tissue on CTP or MRI. So it's not only beyond
4.4 hours. Patient who have beyond 4.5 and there's a hours and there's a salvageable brain tissue, those specific patients, if get a TPA, tenexaplase actually in this case, didn't show improvements. However, it showed it is safe, and also in subgroup, it showed recanalization is better if went to thrombectomy. And however, we need more trial to see if it's safe for patients who did not go to thrombectomy, because those patients in timeless trial, specifically, like most of them were for patients who went to thrombectomy. One last thing, it's not important. There's a new like a sonothrombolysis. It's something also new in the stroke. Usually they do it, there's a, in 2021, meta-analysis for a patient who get ultrasound in addition to thrombolysis to see if they're, for patients who have large vessel occlusion. And those, this meta-analysis showed double like improvement of recanalization for those patients who had sonothrombolysis. This last trial, last thing, there's a trial called the TRUST, and the goal of this trial is to do a randomized trial to study for patients who have LVO and going to thrombectomy and getting thrombolysis, if there's improvement in the outcome of it. But as of current, because this meta-analysis came in 2021, but as of current 2019 guideline, there's no benefit of using the sonothrombolysis. So this is something in the future might be changed, like for the guideline. I'm sorry I got beyond the time, and thank you for your listening, and open for any question.
Thank you very much, Dr. Mustafa. Thank you very much for this very informative lecture, and thank you for your effort and for your time. We also thank all the attendees for attending our event. Before we moving to the Q&A section, I would like to invite all the attendees to join us on social media. We have a YouTube channel, we have a Facebook account, and we have an Instagram. Okay, and all lectures will be uploaded on the YouTube channel too. Next, I'd like to invite all the attendees to attend our next and the first symposium on land. يعني مو ويبينار، راح يكون عندنا ندوة يوم 8/3 إن شاء الله في محافظة بغداد مساء بإذن الله. فندعو جميع الزملاء للحضور لهذه الندوة، راح نعلن عنها لاحقا على التفاصيل والموعد والأمور الأخرى. And we now move to the Q&A section. I'd like to present Dr. Zahraa Hamid. She is a neurology fellow to present the questions of our colleagues and also the opinions. The word is yours, Dr. Zahraa.
السلام عليكم، مرحبا دكتور. I have some questions. Firstly, regarding head trauma, we have some patients presented to AR stroke complicated by fall and head trauma. Are those patients also contraindicated for Achilles?
So yeah, thank you. That's a good question, actually, and more common. So if in the CT head, if there is like signs of severe trauma, which is like a skull fracture, FICH for sure it's not. But if there is a skull fracture, or clinically there is a like obvious severe trauma, like you know, like large bruises, an indication of acute, strong, severe trauma, yes, we exclude them.
Okay, thank you, sir. The second question about combination of thrombolytic and stent revascularization. If the patient failed to get benefit from thrombolysis, can we combine it or follow it with stent revascularization?
You mean giving TPA or tenecteplase before the thrombectomy? Actually, it is a class A. You should give it. Thrombectomy candidacy should not delay or should not prevent giving TPA or tenecteplase. And actually, this, as I mean, one of the trials, the extended trial, giving tenecteplase before thrombectomy improved the outcome than placebo.
Okay.
So yeah, it is strong indication and shouldn't delay it.
Thank you, sir. My third question about which is better, regarding outcome on mortality benefit, thrombolytic therapy or stent therapy?
If the patient is indicated for thrombolysis, he should go. I mean, there's no trial to compare both because the standard of care, the patient is candidate for thrombectomy, he should go for thrombectomy. But tenecteplase or TPA for are not candidate for thrombectomy. I mean, for patient with LVO is not beneficial. That's why the thrombectomy is indicated. You know, like if let's say a patient who have large LVO and we only give a TPA, study showed there's no much benefit compared to the thrombectomy. But combine them, it's better. Does that answer your question? I'm sorry.
Combine them. Yes, sir, that's enough. Thank you. Thank you so much.
دكتور مصطفى excuse me. ممكن نسألك بعد؟
Yeah, sure.
بس نريد نعرف يعني ال percentage of cases you thrombolize versus cases who are shifted to mechanical thrombectomy at your institute. يعني منو الأكثر ده تشتغلون يعني نريد نعرف يعني كإبيديميولوجي خلينا نقول منو أكثر الكيسات اللي تشتغلوها بالطوارئ؟
Like thrombectomy versus what?
Versus thrombolysis.
Thrombolysis. Great. So my center, we are up to like actually last year, we used to be a comprehensive stroke unit. Now we are a primary stroke unit. What the difference is, any stroke that within, not only in my state, we are only the comprehensive stroke center. So in my state and also the neighbors of the state, any stroke patients will come to us because we have a candidacy of like a neurosurgeon 24 hours. That's one of the qualification. We lost one of the neurosurgeons for a short time, and that's why we lost the comprehensive stroke center certificate, and we are primary only. Right now, we are acting like a comprehensive. Why I'm saying this? Because at the beginning, when we are comprehensive, we will see a lot of thrombectomy, a very, very large number. Right now, it's a little bit less because they will divert any thrombectomy patient to different hospitals who are as certificate as us. So back to your question, we see a lot. We get right now the model of practice, like for the past year, any patient go to outside hospital, get the TPA, and he will transfer to us to get the thrombectomy. So maybe it's more a little bit of thrombectomy because they get the TPA outside. But I don't have an exact number of the thrombectomy, but we see between 400 to 600 case of stroke per year. And I would say maybe, I don't have exact number for the numbers, but a good chunk of them are getting a TPA or thrombectomy.
Good. Then my second question, what is the percent of cases who had symptomatic ICH after thrombolysis at your institute, according to your experience?
So I think I have it in one of the slides. I don't have it like in my, we don't do the statistics for symptomatic ICH in
approximate
my institute, but here I think it's in 10, I have it in one of the slides, it's 10 to 20%. It's normal to see like a symptomatic, like an ICH, but that is not something we, if it's symptomatic, ICH, if it's symptomatic, then we hold like the antiplatelet, but for 24 hours. But regarding the percentage, I assume like it's 10 to 15%. But I don't have an exact number because we don't track it here. But I think in literature they mentioned it's kind of expected. Sorry, you're muted. I don't hear you. You are muted. I didn't hear that.
سوري دكتور مصطفى قصدي يعني من مريض عندك مريض انطيته انت حضرتك انطيته ثرومبوليسيس وصار اي سي اتش بدنا نعيش الجو يعني.
For sure. Yeah, for sure. We had like more than one. Actually, you know, it was a little bit unfortunate. Recently, we gave a patient who had 2 years ago or 3 years ago history of subdural hematoma.
Yes.
And he got the TPA, and he was like 85-year-old, and he developed like ICH. The thing is, the ICH is not in the location of the subdural. It was like in the basal ganglia and around like the ventricle. It's actually more of the ventricular bleed. And I mean, it's happened. We see that, but not as a frequent as I don't know the other places. In your hospital, is it like something above 50%, above 25%? What's the percent?
No. Actually, I didn't face a case with symptomatic hemorrhage, but I yet thrombolized about 25 patients, not that much. So I didn't have such case.
I hope you don't see any, but yeah, we see that.
Okay. Dr. Muhammad Tahir, I have a question. Please go on, sir.
السلام عليكم جميعا.
عليكم السلام.
أنا دكتور محمد طاهر كرمنجي, consultant neurologist and trained neurointerventionist. دكتور مصطفى, محاضرة قيمة جدا, عاشت إيدك, ويعني استأنسنا حقيقة بهذه المحاضرة, رغم يعني أنه طويلة لكن ما حسينا بالوقت. أحسنت وبارك الله بيك. وحقيقة يعني كل اللي ذكرته جنابكم هو موجود الآن بالجايد لاينز وبالأب تو ديت مانجمنت أوف ستروك. وأيضا أشكر دكتور مصطفى على تنظيمه لهذا الويبينار بشكل يعني رائع جدا ومستمر. دكتور مصطفى, سؤالي الآن في some of the centers all over the world, especially in Saudi Arabia, بالسعودية, they did and they do CT and CT angio for most of the cases of stroke for many reasons. One, the main reason for research purpose. The second reason, they want to detect the higher number of cases that may need mechanical thrombectomy before thrombolytic therapy, or they also at the same time they can give a thrombolytic therapy to patients who may present late or wake up stroke. So to increase the number of thrombolytic therapy and also to shift patient to mechanical or to give a bridging therapy at the same time. Do you think that in the future we may need, the guideline will change, and we may need to do CT angio, and maybe CT perfusion for any case who presented with moderate to or mild disabling stroke, moderate to severe stroke?
Great question. Thank you. Thanks, Dr. Kamanji. And I'm sorry for the long the long presentation.
Very nice.
So in my center, and actually in all center, I'm trying to find it here if it's in the guideline actually. And in my center, it's a standard of care. Any patient who come with a stroke, regardless of his NIH, like that's even before we go to this, like when I get a stroke pager, a stroke alert, before I reach the ED, there is a CT head and CT angiogram. In addition to the 2 points you mentioned, is like finding LVO, which could present with people who have low NIH, and also to have like the LVO. But also there is a contraindication you can find on CT angiogram that is not there, that like will help you. For instance, if there is a aortic dissection, those patients, you will find it on CT angiogram, and you should not give a TPA. And also if there is a large aneurysm, more than 10 millimeter, those patients might like relative contraindication. So back to your question, I think that should be like a standard of care regardless of the NIH. And I'm trying to open the guideline, AHA and ASA guideline. I'm like confident, but not 100%. There is a recommendation. I'm not sure about the class of evidence. It should be CT angiogram, CT head for every patient who presented with a stroke, regardless of their NIH. I don't know if that's answered your question.
Yes. Thank you. I think according to this, maybe in the future we need, in any case, CT angio at least.
That is, I think, should be the guideline for any institution.
Yes. Another things regarding CT angio, ولو يمكن الوقت يعني استغرق. It is written that it is the best to do CT angio is not only from the arch of the aorta and up. It's also better to include the heart, not to look for the vessels of the heart, but to look for any structural abnormality in the heart to detect sometimes the source of the stroke. Is this also conventional, or is it usual to be done in your institute?
So in my institute, we do CT angiogram, head and neck. But when I say head and neck, that involves going like show the heart, the upper part of the heart, the aortic arch, and going up to like the ICA, PCA, and the ICA and the basilar arteries on the neck. So maybe it's not, back to your question, is not going to help like for the indication, the heart abnormality. Actually, again, back to if there is a aortic arch dissection, that's a contraindication. So that's what we do in our institution. We do from the heart, aortic arch, neck, and the head.
My last question, recently there is 3 studies. One of them is the Swift Direct, and the other one is the Mr. Clean No IV, and also Mr. Clean Non IV not show non-inferiority. Six studies show non-inferiority. They didn't show non-inferiority of mechanical thrombectomy and bridging therapy, but 3 other studies, one of them DVAT or DVET, like this Chinese study, and another Japanese study. 3 studies show non-inferiority of mechanical thrombectomy over bridging therapy. Do you think in the future, with such developmental of the neurointerventions and with more research, we will not give more thrombolytic therapy in the future and only we shift any patient for mechanical thrombectomy?
So, I mean, bridging therapy, you mean like drip and ship with
drip and shift. Yes, mothership or drip ship.
Yeah.
Whether
so,
yes.
Yeah, I didn't look at the Mr. Clean, but if we look at the extended trial, it's what is evaluated tenecteplase before mechanical thrombectomy versus placebo. And it showed higher outcome, benefit outcome. That's one of the studies. I'm sure there's more. There is a higher improvement at 90 days of modified Rankin score for people who received tenecteplase before thrombectomy versus the placebo. So that's a very good example. It's multi-center trial that's having thrombolysis before mechanical thrombectomy is beneficial for the patient. And mechanical thrombectomy candidacy shouldn't delay or prevent thrombolysis. I'm not sure if that's going to, and still that's the recommended guideline even in the UK, but at least in AHA, ASA, that's +1 evidence. But again, especially with tenecteplase, now it's very fast. It's like wouldn't delay you 60 minutes. It's you can give it within like 5 minutes, and it's 1 dose. And I don't know like how, if there is any trial will show benefit of not giving it. But for now, the evidence we have, there is a benefit of giving tenecteplase before thrombectomy.
But if but in case that it is a large vessel occlusion,
and the large vessel
because
occlusion,
it is only 10%. In 10% of the cases, there will be benefit from giving thrombolytic therapy. I think these studies has been done for large vessel occlusion and show that direct mechanical is non-inferior to bridging therapy. And for this reason, this may shift the conventional treatment towards direct mechanical thrombectomy in the future. I mean, this is the reason why we should do CT angio, why we should assess the patient very well according to aspect NIHSS, and then according to the features goes with large vessel occlusion. So whenever there is large vessel, maybe the guideline in the future said no any rule for thrombolytic therapy because the risk of bleeding may be increased and the benefit of reperfusion, recanalization will be very little. So go directly for mechanical thrombectomy. This is my question, that it will be like this in the future.
Yeah, actually, yeah, it's interesting because I think there's now we have a conflict data. And one point I want to mention, I know we go much beyond the time, but it's very interesting. I found it when we look at the extended trial and also the timeless trial. That's the specifically timeless trial that is published last week. When they mentioned recanalization, as you mentioned, like recanalizing, when they compared recanalization versus modified Rankin scale on 90 days, which is the disability at 90 days, that's how they mentioned if there's a benefit of a treatment or not, and that's how the guideline come up. They found there's no, in the timeless trial, they didn't find any, like they don't want correlation. For instance, the TNK showed better recanalization. So there is a better recanalization if you give it before the mechanical thrombectomy versus placebo. However, there's no improvement in modified Rankin scale. So back to your question, I think we have. I think we'll get a closer look at the Mr. Clean trial and the other trials, but extended trial, that's an evidence that giving thrombolysis before mechanical thrombectomy versus a placebo, it's better, showed improvement in modified at 90 days. But I agree with you. Maybe in the future that's gonna change. But for now, the guideline is in that direction.
Thank you. Thank you very much.
Thank you so much. Thank you so much. Thank you.
دكتور سعد كاظم. تمام عمي. دكتور سعد كاظم. هذا comment.
نعم يعني دكتور، شكرا جزيلا دكتور عزيزي، شكرا جزيلا دكتور الخرسان. صراحة time management I think should be more precise.
My camera is not on, so go ahead.
Not for you, for all. Really, I agree with you, and thank you for your nice effort to summarize all details about thrombolysis therapy in acute stroke. My opinion regarding the extended trial had been presented and published in 2019 by Professor Ma, and was a big progress in stroke. But in this trial, we have to investigate the patient with CT angio. Other than CT angio, it is not applicable. So because the window are extended to the 9 hours, so we have to do CT angio, full stop. But in our locality in Iraq, even in the Middle East area, not every city have CT angiography. So the other choice and more easy, more accessible, and available in all hospital in all cities, it is MRI. So we have to apply make-up trial, which is very easy to do for every patient within the time windows. So this is my differentiation between extend trial and wake-up trial. بالمناسبة حتى أذكر لك فد موضوع حلو، نقطة صارت كلش. Professor Thomalu, we met him in 2019 also, and he said when I present my trial, he said after 2 days, one of doctors, he sent me a message on email. He said, I applied this, the guidelines of this trial, and my patients now are going with the details and guidelines of this trial. So I think a wake-up trial, it is more accessible, easy to be applied in our country. Thank you very much دكتور الخرسان. شكرا جزيلا عزيزي. شكرا دكتور مصطفى عزيز. شكرا جزيلا للاستماع.
شكرا جزيلا لحضراتكم. ممنونين. شكرا. تفضل دكتور مصطفى. عفوا تفضل.
Yeah, I mean, إذا الوقت يسمح بك أعلق دقيقتين على هذا الموضوع إذا عندكم وقت. So, دكتور سعد كاظم يعني شكرا جزيلا على تعليقك. Actually, I agree with you. Just a few points. I will add, like here in our institution, regarding the wake-up trial and the extended trial. You want the extended trial. It's not only the CTA. You need to have CT perfusion. So not all. You need to the rapid software. So CT perfusion and to measure if there is a penumbra to do the thrombolysis. So that sometimes some centers have some difficulty having that access. And back to wake-up trial. Wake-up trial showed like use the MRI. As I agree with you. In our center now we are working on getting the protocol. If you don't know like unknown last known well, you just depend on like the DWI and flare. You don't need CT perfusion, you don't need contrast, and even the resident can interrupt it. You don't need radiologist to go over the perfusion and go all these mathematics. But the concept, I know it's depend on the tissue, not on the line, on the time, on the tissue of the brain, but the concept is still not the same exactly. In the extent, it's the perfusion, and in the wake up, it's on the MRI brain tissue. So, but I agree with you, feasibility, it's the MRI for last known well, it's better and more accessible. But again, with Dr. Muhammad, I think CT angiogram should be like a standard of care for any patient who have a stroke to get a CT angiogram for many reasons, regardless of their NIH. But thank you for this session.
شكرا جزيلا. Thank you for all attendees. قبل ما نغادر بس نحب نذكركم بالصفحات على التواصل الاجتماعي، اليوتيوب شانل، عندنا الايميل، الفيسبوك، الانستغرام. مثل ما قلنا المحاضرات will be uploaded on YouTube channel. عندنا الجمعة مو القادمة اللي بعدها إن شاء الله ندوة راح تكون في بغداد يوم الجمعة مساء بإذن الله. فندعو لجميع الزملاء اللي عندهم مجال أنه يعني يرتبون جدولهم بهذا الخصوص. وأخيرا ندعوكم للانضمام إلى الشبكة العراقية للسكتة الدماغية عن طريق ملء استمارة الجوجل فورمز اللي موجودة هنا وموجودة أيضا على التليجرام شانل. شكرا جزيلا لوقتكم. شكرا جزيلا لتفاعلكم وممنونين جدا. شكرا جزيلا.
شكرا جزيلا. أنا طبعا يعني أتشرف بهاي أي أحد إذا عنده I know like I went a little bit above the time, but any feedback what future topics I'm welcome, like more than welcome to share it with me please on my email or I think on my email.
إن شاء الله راح ننقل هذا الإيميل للزملاء إن شاء الله بإذن الله. شكرا جزيلا. شكرا. مع السلامة.